such a great level and handling it in a smooth way. It's only a woman can do it. So proud to be a woman. And on behalf of entire Maharashtra State IAP, I would like to wish one and all Happy Women's Day. What proud moment could be? I had attended Dr. Dhara's couple of webinars. What a beautiful way of explanation and what a simplicity. I'm really very glad that she accepted our request and agreed to take session for us. And indeed, Dr. Dhara, I would love to have online, not online, offline session with you as well. I don't know about others, but yes, I'm really keen to learn many more aspects. Very genuine, gentle, and very beautiful way of explanation. What I have seen you in last couple of webinars, I was really impressed, and I wanted my co-colleagues and friends to have little awareness for yourself. Of course, it's going to help in our professional way. Apart from that, it's going to help in our personal way. So why not have this wonderful Women's Day celebration in a unique way to learn new techniques and tips for our healthy lifestyles? Over to you, Dr. Dhara, and our pleasure. Warm welcome, and really, really appreciate taking out your time and giving us wide knowledge on a special day. Over to you, Dr. Dhara.
Thank you very much, Dr.
Doctor, I'll ask Dr. Asmita. She'll have a little introduction of Dr. Dhara and our state team, and then we'll start with the webinar. Over to you, Dr. Asmita.
Yes, ma'am. Good afternoon, one and all. I, Dr. Asmita Mohorkar, professor at Modern College of Physiotherapy, is honored to introduce central team of IIP, President Dr. Sanjeev Jha, Vice President Dr. Suresh Babu Reddy, General Secretary Dr. K.M. Annamalai, Treasurer Dr. Ruchi Vashne, CC West Zone Dr. Sudeep Kale, Joint Secretary West Zone Dr. Nehal Shah, and CC West Zone Dr. Anchal Vashi. Now we will move on to IIP Maharashtra State Chapter President Dr. Ujjwal Ivle sir, Vice President Dr. Amit Giri, Secretary Dr. Bharti Dave, Joint Secretary and Treasurer in charge Dr. Darshana Trivedi, Joint Secretary Dr. Mansi Mehta, and Executive Committee members are Dr. Suharna Ganbir, Dr. Sanjay Rajhans, Dr. Sohan Shevkar, Dr. Suraj Kantse, Dr. Rahul Deshmukh, Dr. Snehal Patel, Dr. Uttara Mohan, and myself, Dr. Asmita Mohorkar. Now, I'll introduce today's renowned resource person, Dr. Dhara Shah, who is MPT PhD scholar. She is HOD of Pelvic Floor Rehab Clinic at Head Office Aurangabad. She is Chief Clinical Instructor and Team Leader for Teachers Training Program (POW). Her academic contributions are Lead Assistant to Dr. Hed Desai Sir in designing and developing pelvic floor rehab workshops and seminars for physical therapists, gynecologists, urologists, urogynecologists, psychiatrists, sexuologists, oncologists, oncogynecologists, colorectal surgeons, and more. She is MCQ developer and organizer for one of the best book of pelvic floor rehab for doctors, Head's Manual of a Pelvic Floor Rehab. She is also in research and development of under patent pelvic floor rehab like VPEAT and VEASE. She is also a key contributor in designing HETS FSF and HETS MFF. She is a chief executor in designing clinical educational videos for male pelvic floor rehab. Now, I would like to call upon Dr. Dhara Shah to proceed further with endometriosis and pelvic floor rehab webinar. Before that, I request all the participants to please mute the microphone, and if any query or any question, then put it in the chat box. At the end of the session, it will be answered. Thank you all. Over to you, ma'am.
Thank you very much for a lovely introduction, Dr. Bharti. And yes, we will also be very happy to come there and meet you. Me personally would be happy to meet you. Thanks once again for your lovely words, and thank you very much, Dr. Ashmita, for giving a wonderful introduction. Just one thing, I am from Ahmedabad, not Aurangabad. That's okay. That is okay. And Before I start with our today's session, the topic which we have selected is endometriosis and pelvic floor rehabilitation. So before we go ahead, I would really like to introduce all of you to our chairman and founder, Dr. Hed Desai sir. So sir is an innovator, entrepreneur, and author of Amazon's bestseller #1 in urology, Amazon's bestseller in gynecology and obstetrics, and Amazon's bestseller in physical therapy. For the contribution which he has made into the field of pelvic floor rehabilitation, he is popularly known as father of modern pelvic floor rehabilitation. And it is his vision that is to courageously break the cultural taboo and to make the pelvic floor rehab accessible to every single man and every single woman on the globe through innovative technologies and services. With this vision, sir has started Wow IPRI, and I am very much I find myself very lucky to be a part of his great vision and a noble cause. Sir is the chairman and founder of Wow IPRI, that is International Institute of Pelvic Floor Research, Rehab and Education, which has received certificate of recognition from Government of India. Sir is also the chairman and founder of Wow Experience Research and Development, Easy PFM Exerciser, and Vigio, which together have received certificate of recognition from Government of India. To his intellectual property, he has Wow PF360, Wow VSPA, Wow Men, Wow Women, Wow VFit, Wow VDilate, Wow Group mobile application. And to his academic contribution and intellectual properties, he has developed HATES MMT, which is beyond the boundaries of Oxford MMT, HATES FMT, HATES self-assessment, HATES providers protection guidelines, HATES female sexual function scale, HATES male sexual function scale. So like it is always like when we started, people were not considering pelvic floor or sexual dysfunctions or women's health to this depthful with this depthful of knowledge. But with the hard work which he has kept into it, now, like after a few years down the line, we can really see that people are taking a step forward to speak about those dysfunctions. I'm really very grateful to you, sir, for giving this completely different view to all of us to work into a different field of pelvic floor rehabilitation. Going towards my today's topic, which is on endometriosis. Now, this is a very beautiful picture which I have got from Google, which says that just because you cannot see it does not mean that it does not exist. If endometriosis were visible, this is how it might look. Now, what do we mean by endometriosis? So this slide which I have kept itself is a very self-explanatory slide, that what level of pain, what level of dysfunction a female might face if she is suffering through endometriosis. Before we understand what endometriosis is, I would really like to give you a short information about what is endometrium, its position, and what are different pelvic organs, pelvic floor, okay, pelvic cavity organs. So yes, anywhere if you will find me in the webinars, you will always find me with this model, the pelvic floor model, my favorite model. Now, if you can see here, this is the symphysis pubis. Anteriorly, if I just rotate it posteriorly, you can see the coccyx. Inferiorly, you can see the ischial tuberosities on the right and the left side. And this whole, the red colored beautiful muscle is the pelvic floor muscle. And inside this is the pelvic cavity. And in the pelvic cavity, we can see that these are the pelvic organs. So I'm just removing the pelvic organs from the pelvic cavity. It is in this way. So the organs are, they are in this way, right from the anterior aspect to posterior aspect. The first you can see that is just exactly behind the mons. If considering my hand as the mons, just behind the mons, the first is the bladder. Just beneath the bladder, you can see the urethra. Just posterior to bladder, if you can see like this, I'm showing you the lateral view. So just posterior to bladder, you can see there is vagina, and on like postero-superiorly to bladder, we have the uterus. So the uterus is not behind the bladder, but you can say superior or above the bladder and posteriorly. Okay, so you can see this is the uterus, this is the vagina, this is the rectum and the anal canal. If I just move it to give you an anterior view, This is the uterus. You can see the fallopian tubes, the fimbriae, and the ovaries. Right? Now, if I'm just opening this model up for a better understanding, so these are the internal structures, or you can say the internal layers of all the organs. We are not going to discuss about bladder today. We are not going to discuss about the rectum today. Our today's focus is exclusively on the reproductive system, and on top of it on the endometrium and endometriosis. Okay. So now you can see just a quick revision of the things like ovaries. What is the function of ovary? We all know production of egg and regulation of ovarian hormones, estrogens and progesterone predominantly. Okay. Then comes the fimbriae, then comes the fallopian tube, and then comes the uterus. So now when we talk about the uterus, you can see that you can easily see that there are three different layers of uterus: the outer layer, the middle layer, and the inner layer. Okay, a very beautiful structure, and every female would be really proud to have a uterus, because this is the structure which gives us a wonderful opportunity to be mothers. But the same structure can even be disabling, can even lead to disabilities or disabling conditions like endometriosis. So today's talk about is endometriosis. Now this is the perimetrium. You can see the outer layer of uterus. This is the myometrium, or you can see the uterine muscles. So the perimetrium is like a connective tissue or a supportive layer which will protect the uterus from a sudden thirst or concussion, which will separate the uterus from other organs. Okay. The middle layer, that is the myometrium or the uterine musculature, the uterine muscles, which is responsible for contraction and relaxation of the uterus, or the expansion and contraction of the uterus. So we all know that the uterus would contract during menstrual cycle, during sexual activities, and during the parturition or childbirth, and it as such relax and expands during the pregnancy. The next layer here you can see is the endometrium. Right now, when we talk about the functions of the endometrium, so this is the layer, the innermost layer of the uterus, which grows for the 14 days of the menstrual cycle, and then it proliferates, and at the end of the menstrual cycle, it sheds or it breaks down, and that is what is coming out as a menstrual discharge. So whatever menstrual discharge we have, it is nothing but it is the shedded or the broken endometrium, the vaginal discharge, and the other discharge of the linings. Okay. Now this endometrium or the endometrial cells, they are present inside the endometrial cavity, but in a condition known as endometriosis, those cells, they are present, though not just the cells but the functioning cells. There is a difference between presence of cells and presence of the functional cells. Okay, so when this endometrial cells, the functional cells, they are not present only in the uterus, but they are present anywhere in the pelvic cavity or the abdominal cavity. That condition is known as endometriosis. Okay, there is a difference between endometrial hyperplasia and endometriosis. Many of us, we get confused in these terms. So endometriosis, or sorry, endometrial hyperplasia, when we say, that is a hyperplasia or overgrowth or thickening of the endometrial cell, which is endometrial lining, which is present in the uterus. But the terminology endometriosis, that means the presence of the functioning endometrial cells. Why I'm emphasizing this word so much? Because according to some research, they say that almost into 95% of female, the endometrial cells are present in the pelvic and the abdominal cavity, but only in amount in around 5 to 10% female that develops into endometriosis. So it does not mean that the presence of the endometrial cells into the pelvic cavity or the abdominal cavity or outside uterus is endometriosis, but the functioning, the presence of the functioning cells is endometriosis. Okay, now this functioning endometrial cells or the functioning endometrial linings will not be just restricted to the endometrium or the cavity, but it is found outside the uterus. So it can be found anywhere into your pelvic cavity, into your abdominal cavity, and there are only less than 5 case reports which are saying that the endometrial cell can be even present into the cerebellum or the cerebellum or the cerebrum. Okay, so either like it can be even transported to the brain, and then it becomes a life-threatening condition. Okay, so the presence of the functioning endometrium outside the uterus is the endometriosis. Okay, and these structures, and why is it so disabling? Is it life threatening? If it is into this cavity, it is not life threatening or fatal, but it is very much disabling. Why is it very much disabling? Because see, endometrial cells, they are hormone receptive cells or hormone responding cells. So wherever they are, wherever they are located, if there is any hormonal change, it will reflect the functioning of the endometrium. So if we understand the normal menstrual cycle, so what happens in the normal menstrual cycle is that under the influence of follicular stimulating hormone on the your ovaries will begin the process of the follicle maturation process, that is the follicular phase will start into the ovaries. If today is your first day of menstruation, means your endometrial lining is getting shedded and it is coming out and you're menstruating. So today your ovaries will again start the process to mature your next egg. Okay, so follicular genesis again is a very detailed topic, not going in details of that, but just for an understanding of how the hormones affect. So now, as the ovaries will start its function of maturing the other follicle, so there will be release of estrogen hormone. And these estrogen hormone, which is released by the ovary, will stimulate the endometrial linings to start its maturation again. Because your body prepares itself for pregnancy every month. And since you are not conceiving, it sheds off the formed endometrium. Okay, so now when we talk about the this estrogen responding tissues, so as the ovarian estrogen increases, so is the endometrial cell thickening increases, or the proliferation of the endometrium increases. Okay, so no matter where these cells are, they will respond exactly the same way. So here what I mean is, if the endometrium cells are present in the cavity, they will grow, they will proliferate here. But if they are present outside the cavity, still they will grow and they will proliferate there. Okay, so the growth of the cells will take place wherever it lodges. Okay, so that's why I said that the presence of the functioning endometrial cells, not just the endometrial cells. Okay, so functioning means they are responding to the changes in the hormonal levels. So these cells, suppose this cell is present, the endometrial cell is present into the fallopian tube. It can be present anywhere. So supposingly it is present in the fallopian tube. So in the fallopian tube, those cells will start maturing, those cells will start proliferating. And as you proceed further into your menstrual cycle, so on 14th day, suppose you're ovulating, then you enter the luteal phase of your ovarian cycle and proliferate secretory phase of your uterine cycle, and then your body will wait for the conception, and if you have not conceived, you will menstruate. So what happens, how are you menstruating? That is, a sudden drop in the estrogen and progesterone levels leads to the what triggers your menstruation. So a sudden drop of estrogen progesterone levels triggers your menstruation. Okay, so when the shedding of the endometrial cell gets activated into the uterus, so the same shedding or the same breakdown or the same responsiveness happens into the fallopian tubes as well. Okay, but here comes the difference. The shedded cells of the endometrium inside the uterine cavities, they come out of our body in the form of menstruation, but the shedded endometrium, which is lodged in the maybe fallopian tube or over the ovaries, or in rarest case even into the bladder, it does not leave the body. Rather, it breaks there, it bleeds there, and it forms adhesions, it forms fibrosis, or even hemorrhagic cysts. Okay, that is blood filled cyst. It forms a cyst. So either it can form adhesion, it can form fibrosis, or it can form cyst. And that is the reason this endometriosis or endometrial cells, which are not into the uterus, they are disabling, because they end up, the female end up into extreme pelvic pain, menstrual pain, heavy bleeding, infertility, sexual disturbances, and a lot more. So let us now go the slide. Yeah, so the next questions which can come up would be, why does the endometriosis happen? Like, if the cycle, the process is shedding of the endometrial here and bleeding outside the body, then why does in 5 to 10% female this endometriosis is there? So the exact cause is not known. There are still researches, medical studies going on to know the exact cause, but there are few theories, you can say, or few conclusions which are put forward which can support this endometriosis. So one of it is retrograde menstrual blood flow. What do we mean by retrograde? Retrograde means backflow, right? So retrograde menstrual blood flow, that means that if in case, I can see that there are few chats into the chat box, but let us address all the questions at the end of this session. You can just keep them in the chat box, right? So now the normal course is shedding and bleeding, but in retrograde flow, what happens is shedding of the endometrium inside and backflow of the fluid into, backflow of the menstrual discharge into the fallopian tubes, then through the fallopian tubes into the fimbriae, then through the fimbriae into the pelvic cavity. Okay, so the blood which should come out, or the discharge which should come out, instead of coming out, it goes backwards towards the pelvic and the abdominal cavity. And one thing, like to just for a better understanding, see this ovary, you can see that the ovary is connected to the fimbriae here, but this is not the structure. This is for an understanding, they have kept like this. Instead, the ovary and the fimbriae, they are not connected. The fimbriae, they are free floating near the ovary. So if this finger is the ovary, then the fimbriae would be like this. It's not band like, okay, it's open. It's not connected. During ovulation, what happens is the fimbriae will come more close towards the ovaries so that they can catch the released egg. Otherwise, the egg is also released into the pelvic cavity surrounding. Okay, so it's not released inside the fimbriae, and the fimbriae will then just engulf or just collect the egg like this. Okay, now, so you can understand that if if this is this is the uterus, so this is the uterus and this is the fallopian tube, the blood which should go down, instead of going down, it is coming back, and then from the fimbriae, or from this output, the blood is the shedded endometrium is coming out, and this shedded endometrium which has come out then can get lodged between, it can get lodged in the anterior cul-de-sac. Anterior cul-de-sac means anterior to the uterus, posterior to the uterus, anterior to the uterus. It can be between the uterus and the bladder, or the vagina and the bladder. Okay, or it can be over the ligaments, or it can be into the fallopian tubes, or it can be over the ovaries, or it can be posteriorly near the rectum, near the anal opening. Okay, near the anus, near the rectum. Okay. So these cells can go and lodge, and if they lodge, if they proliferate, they become endometriosis. Okay. The next theory, so this was a theory of retrograde blood flow to justify endometriosis. Other theory is it is genetics. It flows in genetics. So if the mother or the Masi or someone from the side of the mother, if she has endometriosis, then the chances of endometriosis to the next generation increases. So other cause is genetic. The third cause is a lymphatic flow or a blood flow, okay, through blood channels or the lymphatic channels. So that means the way your cancerous cells travels from one place to other place, similarly the endometrial cells, they can also travel from one place to other place. But it is not it is not cancer, it is not tumor. Endometriosis, it is not a cancerous condition. Endometrial cancers, they are different, okay. So endometriosis is not it is not a malignant, but it can metastasize, in the sense it can shift from one place to other place, okay. That is the blood or the lymphatic channel flow can even happen, and that is the theory which explains that how does the endometrial cells can lodge into the brain, okay. So though the case reports are very few, but they are. So that is the third flow, that is the blood flow or the lymphatic channels. And fourth theory is like iatrogenic cause during cesarean section. So whenever a female goes for a cesarean section, so like you can assume this to be a pregnant uterus, and then you are going for a cesarean section over here. So if you are going for a cesarean section and while removal of the fetus and then the placenta and cleaning all process, so at that time there are chances that the endometrial cells can shed out into the pelvic cavity, or even during the hysteroscopic procedures or DNC or DNE, dilation and evacuation or dilation and curating, there are chances that the endometrial cells can get lodged over the vagina, the cervix or the vulva, and then they can end up into endometriosis if they prefer to function. Okay. So, and there is one more theory which says that even the stem cells, some of the stem cells, because of the genetic predisposing factors, the stem cells, they differentiate into endometrial cells and can lead to endometriosis. Okay. So these are few of the theories behind to justify the endometriosis. Yeah, the locations which we already discussed, the location can be into the fallopian tube. Now, if it is into the fallopian tube, what can happen? Okay, so you can understand here that if the endometrial cell, they grow into the fallopian tube, okay, they lodge here, they proliferate, they break, they shed. Okay, so what can happen? It can lead to blockage of your fallopian tube. Okay, so I simply have to explain you. I'm just drawing a fallopian tube here. This is the suppose a fallopian tube, and here is the endometrial cell which is lodged. So what will happen? It will break, shed, and then it can form a blockage. It can form the fibrous septations, or you can see it can form adhesions. So these adhesions or these fibrous septations can lead to infertility. So if you just Google the causes of infertility, maybe the second or the third cause you will find out would be endometriosis. It's that common. Okay, they say that out of 10 females, almost around 3 females, they are suffering through infertility because of endometriosis or blocked fallopian tubes. Okay, so this blockage of the fallopian tube can result into endometriosis, into infertility. Okay, ovarian endometriosis. Okay, so there is a term, if you are into women's health, or if you are seeing the females who are suffering through endometriosis, so you might come across a very common terminology, that is endometrioma. Okay, endometrioma, what does that mean? That means the cysts which are formed over the ovarian areas because of endometriosis. Okay, So as I said, that three fate can happen to the endometrial tissues which are present outside the uterus. They can break, they can form adhesions over there, they can form fibrous septations, or they transform into cyst. And generally these cysts are the hemorrhagic cyst, or you can say the blood filled cyst. Generally, okay, there can be other variations as well. So now endometriomas, that means the cystic formation over the ovaries. Okay, if the endometrial cells are present over the ovaries, they grow, proliferate, and then they convert into cyst. And these cysts, they are known as the endometriomas. In certain case, they are also termed as chocolate cyst. Why is the word chocolate cyst given? Let me show you from one of the pictures which I have kept. Yeah, here. This is not a typical one, but you can see these are the these are the lesions. Can you see? So this is the uterus. Okay, they have taken the superior view, so you can see like this. So this is the uterus, and then you can see its fascia. And here, these are the lesions. Can you see the lesions here? Okay. So in case of endometriomas, and if there are multiple endometriomas, it can happen that the constant shedding and bleeding of these cysts inside can lead to adhesion of all the surrounding structures. All the surrounding structures, I mean the uterus, the rectum, the anus, the bladder, the urethra, everything gets stuck together, and that's why it is termed as a chocolate cyst. Okay. So if these chocolate cysts are very severe, and if the female is presenting with a complaint which is not just limited to sexual like penetrative disorders like sexual pain during penetration, but they are also leading to a lot of defecatory disturbances or painful defecations and painful urination, chronic pelvic pain, and very severe presentation of these, then the ultimate solution is they go for a complete hysterectomy. I mean to say uterus, fallopian tubes, ovaries, everything is removed in that case. Okay, and then the other procedures are being taken. So yes, so that is what is endometriomas. Okay. It can be present in the anterior cul-de-sac or posterior cul-de-sac. Now, anterior cul-de-sac, posterior cul-de-sac, I already mentioned that the area between the uterus and the bladder, and the area between the uterus and the rectum, that is posterior, this is anterior. Near the surrounding ligaments in the pelvic cavity, even at times it is present into the abdominal cavity near the intestines. So if it is near the intestines, it can lead to the obstruction of the intestines or adhesions of the intestines with one another. Or maybe the bladder. If the endometrial cells are present inside the bladder, not on the bladder, but inside the bladder, that can even lead to painful bladder syndrome or interstitial cystitis. Okay. We are not the right one to diagnose what it is, interstitial cystitis or not, but you can get this as a associated finding with endometriosis. They generally say that endometriosis, interstitial cystitis, and irritable bowel disease, these are three sisters, or you can say three best friends who go hand in hand. Okay. Yeah, it can be present over the vagina, on the outer layer of the uterus, the rectum, the cervix, the intestine, the vulva, or even into the abdominal scar tissues. Okay. So these can be the various presentations of endometriosis, and they can have a severity from mild, moderate, severe to very severe. Okay, so grade 1, 2, 3, and 4. So there can be various severities of endometriosis presentations as well. All these images which I have taken from Google. So image courtesies to Google. Now, how can you understand that whether this is a female suffering through endometriosis, or see, generally in the earlier days, these dysfunctions were not that common, and the presentation was also not that frequent, like maybe 1 in 10 or like that. But because of the lifestyle modification, the involved stress levels, other pollutants, and all those things, now generally it is said it is more frequently seen and more more frequently seen dysfunction, and it can even be present. Earlier it was said that the endometriosis presentation is into 30s and 40s, but now even young girls who just have started their menstruation, they can also come up with these types of symptoms, and they can also have a diagnosis of endometriosis. Okay, so even from a female's personal point of view also, it is really important that you educate every girl about menstrual health and what is normal to expect during menstruation and what is abnormal, or when should you quickly think about, yes, this is not my routine menstrual cycle. Okay, so if the female is suffering through excessive pain during menstruation, what do we mean by excessive pain during menstruation? That means dysmenorrhea. Now, dysmenorrhea, not going into detail, can be of two types: primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea means there is no underlying pathology. The prostaglandin activity is so high for the female that she has extreme pain. Okay, but that pain will not be so much that it comes with defecation, it comes with urination, and it leads to you rolling in the bed throughout the day and not doing a functional activity. Okay, that pain would be still manageable. It can still reduce with maybe antispasmodics or something given by your gynec. But if the pain is so severe that it is not been reduced by any of the painkillers or antispasmodics, and the pain is so severe, it also increases during urination, during defecation, and you need to take a break from your work. That is something which can be a secondary dysmenorrhea. Secondary dysmenorrhea means due to an underlying pathology, you are having this aggravated pain, and that pathology can be endometriosis. Okay, spotting between the periods. Yeah, one of the case study of endometriosis, a 30-year-old female delivered 6 years back through vaginal delivery, already had a history of endometriosis, for which she had gone for a laparoscopic removal of the endometrial tissues, and then she conceived, and now after 6 years down the line, she was not having menstruation like from past one and a half month. She thought that she's pregnant. She went for an UTP that came out to be negative. Then she used to have on and off spotting, not during the days, but here and there. And when she went for for an investigation, it was a chocolate type of an endometriosis involving almost all the areas of the pelvic cavity. It was near bladder, it was near rectum, it was near anal canal, it was near the urethra, leading to, and then slowly the symptoms increased, eventually involving all her activities: urination, defecation, sexual activity. Ultimately had to go for a total hysterectomy, removal of ovaries, fallopian tubes, uterus, and everything. Okay, so a very important thing, the most important thing is to be very much aware about your menstrual health. See, many of the females, they feel that I'm not sexually active, or it's okay, like I'm married, I want to conceive, and it's okay if I miss period here or there. But it is not just that missing period here or there, or not bothering about it because either you're not sexually active or you want to conceive. Menstrual health and awareness of your own menstrual cycle is important at each and every phase of your life, no matter at puberty, no matter during childbearing ages, or no matter you're reaching menopause. It's not just because of pregnancy ka issue, because your body talks with you. Your body tells you that, yes, this system is right, this system is wrong, this system is here, this system is there. And how does the reproductive system talks with you? That is with the help of the menstrual cycle. So if you find any of the change in your cycle, please don't consider it to be okay. Please try to see that whether that change is happened just once or it is occurring repeatedly. And if it is occurring repeatedly, earlier is better. Okay. Painful intercourse, heavy abnormal menstrual blood with excessive blood clots. Yes, this is one of the finding. Many endometriotic patients might come up and say that I have heavy blood flow, not just heavy blood flow, but clots, excessive blood clots during menstruation. Okay. Painful urination, painful defecation. Again, not in all the cases. If the endometrial cells, they are not lodged or they are not irritating the bladder and the urethra or the rectum and the anal canal, then they might not present with urinary or defecatory disturbances. But majority of time they are present with this painful sexual intercourse. Okay, chronic pelvic pain, low back pain, excessive premenstrual excessive premenstrual symptoms, and infertility. So these can be the diagnosis of endometriosis. Diagnosis are routinely be done by CT scan, laparoscopy, and MRI. There is one more thing, which is hysterosalpingiography, but hysterosalpingiography is taken when you have to see the patency of the tube, okay, the fallopian tubes. So in that, a high pressure opaque gas is passed through the vagina, and then an X-ray is being taken to see that how is the flow of the gas. So usually if there is no resistance or no blockage, the gas will enter through the vagina, throughout the uterus, and will spread across the fallopian tubes. That is hysterosalpingiography, but that's not a diagnostic factor for endometriosis. It is a diagnostic factor or maybe a therapeutic at times for the blocked fallopian tubes. But to diagnose endometriosis, CT scan, laparoscopy, and MRI are required. The medical management is take OC pills, no hormones, no growth, but that's not done. You cannot go for a long-term OC pill. It will affect the negatively. Other is hormone replacement therapies. At times they have been given the GnRH inhibitor injections, so that there is no, it is like a medical menopause, a laparoscopy, or a laparotomy, or hysterectomy. And yes, one more management to it, though it is not permanent, but time being, that is pregnancy. Okay. So if suppose you are 28 years or 30 years or 32 years and you are diagnosed with endometriosis, your doctor would advise you for a laparoscopy, and then they will say you that you try to have a pregnancy or try to conceive immediately within 6 months or as soon as possible, depending upon your other general findings. But yeah, in general, they say so. Why? Because of two reasons. If you become pregnant, there will be a momentary stagnancy into your endometrial growth. So your endometriosis will settle down for a few more months, and then during lactation period for a few more, like almost 1.5 to 2 years, you are safe, and then again it starts. Okay. Second reason is, like, when they go for a laparoscopy, they will check the patency of the tube. They will open all the tubes, and they will almost like clean that area. So if they're cleaning that area, that means chances of fertility increases. Okay. So with these two reasons, they might ask you. Now going to the pelvic floor, that ultimately, like, how is the pelvic floor muscles involved? Not going into detail of pelvic floor muscle anatomy, okay, but just an idea to the layers. So we basically have 3 layers: superficial layer, middle layer, and deeper layer. Middle layer and deep. Superficially, we can have we have 4 muscles: bulbocavernosus, ischiocavernosus, superficial transverse perineal muscles, and the external anal sphincter. In the middle layer, we have deep transverse perineal muscles, and in the innermost layer, we have the levator ani. There are multiple books which consider pelvic anatomy in pelvic floor muscle anatomy in different way. It is okay, whatever you feel easiest way to remember, you can remember. But there are multiple school of thoughts for the pelvic floor muscle presentation. So superficially, you can see the bulbocavernosus from the perineal body towards the clitoris. I'm not going in detail on the pelvic floor anatomy. Itself, we can have a 1-hour lecture for that. Okay. So bulbocavernosus, ischiocavernosus, superficial transverse perineal, and external anal sphincter. Then we have the deep transverse perineal muscle, that is the middle layer, which also forms the urogenital diaphragm, compressor urethrae and urethral compressors, and uretrovaginal sphincters. And we have the deepest layer of pelvic floor, that is the levator ani. Okay. So you can see in the levator ani, there are a few muscles which are running all across. So just for an easy understanding, symphysis pubis, coccyx. So a muscle running from symphysis pubis to coccyx is the pubococcygeus. You can see the pubococcygeus. Then from, you can see the obturator internus here and the fascia of the obturator internus. So muscle from the fascia of the obturator internus back, just lateral to the pubococcygeus, is the iliococcygeus, and the lateral most is the, this one, is the coccygeus. Okay. So pubococcygeus, iliococcygeus, and coccygeus. Again, the life is not that simple. We have three openings: urethra, vagina, and anus. So the medial most, that is the pubococcygeus, has to give way to these three openings. And so we have pubourethralis or pubovesicalis, pubovaginalis, and puborectalis. Okay. So pubourethralis, pubovaginalis, or puborectalis. Those are the internal muscles. And since the organs are so much in close vicinity to these muscles, okay, so you can see how closely these structures are located. So any pain or any adhesions or any fibrous changes which happens in the pelvic cavity would directly lead to a tightness of the pelvic floor muscle, and indirectly in response to the pain will also lead to tightness of pelvic floor muscles. So generally pelvic floor dysfunctions are broadly categorized into hypertonus, hypotonus, and incoordinated. But typically seen presentation of pelvic floor in endometriosis is either incoordinated or hypertonus. Hypertonus means the muscles are in spasm, they are in pain, they are tight, and they are not relaxing completely. And that's very logical, right? Like if you have a cervical pathology, if you have something going on into your cervical spine, then there are more chances that your neck muscles, though they are weak, but their primary finding would be tightness, pain, spasm. So same it is with your pelvic cavity. Your pelvic floor muscles would go into tightness, they can go into spasm, and they can give you unbearable pain, which can lead to sexual disturbances, dyspareunia, or in certain, in severe cases, vaginismus. Okay, so that can be the pelvic floor muscle involvement leading to hypertonus dysfunction. And how can we understand that whether these pelvic floor muscles, they are hypertonus or hypotonus? So a very simple test, I would really like to request you all to understand this and to implement it first on your own self. Because see, we are taking so much care of our face, we are taking so much care of our external health. I shouldn't be overweight, I shouldn't be, you know, fall into the category of obese, I have to work out and I have to do these and that. But when it comes to your private health, when it comes to your intimate health or your inner health, we are not knowing at times that where do we fall. Are our pelvic floor strong to sustain a pregnancy or to avoid a urine leakage or to protect the organs, or they are so tight that they cannot perform the activities the way they should? Either are my muscles normal, or they are extremely tight, or they are very loose. So the way you are giving importance to your breast examination, your other parameters, your vitals, it is really important to take care of your intimate health, personal health as well. Okay, so I would really request from this platform, I would really like to request all of you to at least self-examine your own self. Okay, you should know that where are you falling into, which category you are into. Okay, so the pelvic floor assessment was priorly done using the modified Oxford scales or the Oxford grades. You can see the Oxford grade here, but there are two major limitations to Oxford gradings. One is it cannot assess the if you have a patient with dyspareunia or vaginismus. So in these cases, the female are reluctant to the pelvic to the and they have so much pain that they do not allow a penetration. Their muscles are tight. So if that is the case, how can you assess the strength of the pelvic floor? In order to measure the strength, you need to first penetrate. And to penetrate, you need to first relax. So until and unless you do not check the relaxation, there is no way you can check the strength. Okay, so that is one limitation of modified Oxford grading. Another limitation is the terminologies which are being used. They are quite vague. It is weak, fair, moderate, good. Now, something which is weak for me can be fair for you. Something which is fair for you can be weak for me. So there is no one rule or no one line of understanding. If this is the finding, these are the things. Okay, so it is not clarifying that hai ya nahi hai. It's quite vague. And for that purpose, like looking over this limitation, and through his years of practice, Sir innovated Hates MMT, which is taking care of the limitation of modified Oxford MMT. See, the era is changing. If we are updating in all the fields, why not shall we update into our older practices as well? Okay, when Oxford MMT was invented, maybe the understanding of pelvic floor was not in this much depth. But now, when the understanding is growing, it is really good to use simple yet efficient tools. And that's how Sir developed Hates MMT. Again, I would request all of you to assess your pelvic floor with this once. So if I'll quickly explain you, if 0 is the baseline tone, 0 is the normal resting tone. We all are sitting right now. Some of you might be standing practicing, but you might not be using your washrooms or doing your bladder work right now. Okay, so if you are sitting at present, you are not consciously using your muscles, still your pelvic floor will have a baseline tone. It will not be relaxed, otherwise the structures would fall out. It has to maintain a baseline tone to support the structures. Okay, so that tone is 0. Okay, now when you are examining a female and on the on the palpation itself, she's giving you a response that it's very painful, ma'am, please do not touch, everywhere she has pain. Okay, it's very much painful on even on palpation. She has pain, tightness or discomfort. She's not allowing you to penetrate. That is a grade of -1. If she allows you to penetrate, but that is with symptoms of tightness, pain or discomfort, any of these symptoms are present, that is a grade of -2. And if she can, so she allows you to penetrate, but that is with symptom, it is a symptomatic penetration, that is -2. And if she allows you a easy penetration, okay, completely you are asking her to relax and she is relaxed without any discomfort, that is -3, a grade of a complete asymptomatic penetration or a easy penetration. So -1 is inability to penetrate, -2 is painful penetration, and that can be pain, tightness, discomfort or any other symptoms. And -3 is a complete relaxation. Okay, great. Now once you are inside and you want to check the strength, so you asked her that squeeze as if you're trying to hold your finger. And when she is squeezing, and you can see that there is just a mild contraction from either side. There is no complete grip, but a mild contraction from either side. That is grade 1. If there is a complete grip over your finger, that is grade 2. And if there is a grip and a strong upwards inwards pull against resistance, that is a grade 3. So you can understand either there is a grade 1, just a mild contraction, or there is a grip, or there is a pull. So there is no point of weak, fair, moderate. It is crystal clear. It's black and white. Okay, so that is Hates MMT. There are few grades for hypertonous dysfunctions like Lemont's grade, but Lemont's grade is giving you an idea for the readiness of your patient for an examination. It's not giving you an idea that whether the pelvic floor is involved or not. And you being we being pelvic floor rehab practitioners or musculoskeletal practitioners, we have to understand that whether the muscle is involved or not. Psychological involvement, yes, it do fall under us, but not just for us. Okay, we have psychologists for that. So this Lemon's grade, it shows you the psychological involvement, or you can say the readiness for the examination. It does not give you an idea that what level of pelvic floor it is involved into it. Okay. The next grades which are used to check the sexual function, because the females who are suffering through endometriosis do have a lot of sexual disturbances. They can present with vaginismus, or they can even be present with dyspareunia. So the female sexual federation index, which been developed by International Urogynec Association, it is a scale which was being used, but the counting of the scoring is quite cumbersome. So the data analysis becomes quite cumbersome. It is not in response to the pelvic floor muscle involvement, and it is not separating that whether the patient suffering is from hypertonus or hypotonus. So in order to take care of these limitations, CERD has developed Haig's female sexual function scale, and this scale has two separate parts, hypertonus and hypotonus, and it can give you a clear picture that where the female is. So the highest score is a score of 50. The whole female sexual response cycle is been divided into five sub phases, and every five sections have one rating question that gives you an idea that where you are. If you have a grading of 0 to 25, that shows poor sexual health. 25 to 40 shows average sexual health, and 40 to 50 shows good sexual health. And an objective way to find, like, if suppose a fee, like many patients, they come to us, they say that, madam, if we knew about this condition, this pelvic floor condition priorly, we might not have wasted this much of time. And that's so true. If you know that you are suffering, you might not run here and there and invest a lot of time, energy, and efforts. So an objective way to grade your pelvic floor muscle is through VEs, that is for hypertonus. So this is the VEs. Again, this is an intellectual property of Haig sir. And he thought that if we can give a functional diagnosis or a functional muscle grading, that will be better, because our treatment is functional. Our treatment is not to achieve a static goal, it's to achieve a functional goal. So if the female could not penetrate the narrow end, that is C, extremely tight pelvic floor. If she can penetrate the narrow end and the broad end, but with symptoms, okay, but with symptoms, that is grade B, still a tight pelvic floor. And if she can have a easy and pain-free penetration without any symptoms, that is A, a completely relaxed pelvic floor muscles. Okay. Quickly giving you an intro to what we can do into pelvic floor rehab. So see, if the patients who are suffering through endometriosis, sexual dysfunctions, or infertility, they will need a lot of psychological support as well, and they will need lot of other supports also. So first is the pain management. You need to manage the pain. You need to reduce the pain. You can use cryotherapy, you can use IFT, you can use ultrasound, you can use relaxation technique, you can use guided relaxation. Second is relaxing the pelvic floor muscles, perineal stretches, trigger point release, soft tissue release, soft tissue mobilization. Teaching them proper penetrative techniques. Many of the couples, they do not know that how to penetrate. Okay, we being medico, we might find it interesting that how don't they know, but laymen, they really find difficulty in understanding that how to penetrate. Okay, so teaching them proper penetration techniques, meditation, stress reduction, lifestyle modification, and other overall symptom management. So that would be our role. And this is the last thing of my, and this was just an overview of what we can do. Okay, there is a lot of hands-on techniques which we are conducting into our webinars and workshops. A quick introduction of what WOW IPRE is. So it feels a real privilege to say that WOW IPRE is the innovative. It is an initiative of WOW Group under Dr. Haig Desai sir's leadership, and it is the only government recognized institute for pelvic floor education. So WOW IPRI is the only government recognized institute for pelvic floor education, and it has received a legitimate DIPP number for specialized training of transvaginal transrectal pelvic floor rehabilitation, to train and place skilled pelvic floor rehab specialists, and to improve education and employment in doctors, businesses, and services. We are the global brand, and we are training almost in 13 countries all over the world. So it's more than 7 countries now, and it is really a proud feeling that we, being Indians, sir being an Indian, had developed an institution which is training across the globe. So it is a proud moment for us as well. Sir's authenticity, I already had mentioned that the book is a recommended textbook in the Masters of Physiotherapy Women's Health, Gujarat University. Uh, and to the other brands of WOW IPRI, we have, as I already mentioned, WOW Experience Research and Development, Easy PFM Exerciser, Vidyo, WOW Group Mobile Application, World Pelvic Floor Organization, and WeCare. And HATES MMT, which we recently discussed, is also being proudly introduced by the Gujarat University in the syllabus of Masters of Physiotherapy Women's Health. So yes, this is our upcoming webby workshop. If you are interested, you can join us in Belgavi, 9th and 10th April. It will be in KLE University. So it's on 9th and 10th April, where we would be discussing about the hands-on techniques, how to go for trigger point release, how will you palpate obturator internus, how will you palpate all the pelvic floor muscles transvaginally, transrectally, how will you go for coccyx mobilization, how would you assess that, which muscle is tight, which muscle is involved, how to go, how to penetrate, what level to penetrate, which direction shall you palpate, where will be the urethra, where will be the G spot for the sexual dysfunctions, how to work upon a female who has an patient who has in sexual disturbances, how to work upon the clitoral area, how to go for para-urethral muscle strengthening. So all these things we would be discussing into our upcoming workshop. So if you if you want to enroll, you can contact me on my mobile number, that is 8005211503. And if you really want some, you can, if you want to get the study material or scales, whatever we are using, or any other assistance, feel free to WhatsApp me with your name on my mobile number, that is 8005211503. You can note it down. And last but not the least, thank you very much from WOW Group, from Hed Desai sir, for joining a war against silent suffering. And I would also like to thank Hed sir for opening this new opportunity and giving us an insight of a deeper understanding of women's health, pelvic floor, and not considering sexual dysfunction a taboo anymore. Last but not the least, I would really like to thank our today's moderator, Dr. Ashmita, Dr. Bharti, the whole team of IAP Maharashtra State, and IAP India, Dr. Sanjeev Jain, Dr. Ruchi Vashmi. Thank you very much for having us today. This is it from my side, and we can have the question answers if any. I hope you have got some information about this subject.
Thank you, Dr. Dhara. It was a wonderful session, and the way you explained everything in short, crisp, and a smooth way, I think takeaway message is very clear: women's health on priority and your health check in your hand. So very well explained, Dr. Dhara. We have some questions. So one question asked is the difference between endometriosis and endometrial hyperplasia.
So the thing is, like, I already discussed that. Let me explain it once again. When we talk about endometrial hypoplasia, that means the endometrium, which is present into the uterine cavity, the endometrial cells, they proliferate or they become thick, but it is only into the uterus. So in this condition, the uterine lining, they become more thicker, they grow and they do not shed, or they shed irregularly. So it can be presented as DUB, that is dysfunctional uterine bleeding. So the cases might come up. You can see females who are about to approach their menopause, or they are into the premenopausal age group, where they are presenting with menstrual bleeding which is lasting for more than 8 days, 10 days, and again they like this they the menses start, and again it starts within 10 days, and it again continues for 8 10 days. So that is a dysfunctional uterine bleeding. There are multiple other causes, but one of the causes is endometrial hyperplasia, where the endometrial cells, they proliferate more, or they become more thicker into the uterine cavity itself. Okay, and endometriosis means the endometrial functioning cells, they are not limited to uterus, but they are present outside the uterus. Okay, so that is endometriosis. So like endometrial thickness varies throughout your menstrual period, throughout your menstrual cycle. Okay, but if it is more than 12 during your ovulatory phase, that shows more than more than 12 to 15 into your ovulatory phase, that shows endometrial hyperplasia. Okay, again that varies with your age, with your ethnicity, with your race, but this is a rough estimate to do that. Clear, I
Okay.
hope.
Yeah. I think you have given again enlightened on the doubts. Second question, I just clubbed two questions together. How to overcome endometriosis, and can we conceive with endometriosis? This was one of the question wondering in many of the listener.
See, how to overcome. So let me be really very clear. The management of endometriosis is not just pelvic floor rehab, or not just physical therapy. It is way beyond that. See, we can control the symptoms, we can control the hormonal regulations up to an extent by going for routine exercises, by going for stress reduction, by going for certain yoga postures, not during menstruation but other than menstruation, and following a pelvic floor rehab. But if it is a case where it is more than a moderate type of endometrial growth, if the patient is going towards more than moderate, like severe to very severe, then it will require a medical and a surgical intervention. So the ultimate thing is laparoscopy. If someone says that without laparoscopy it would be cured, then either the condition should be, at times the endometrial cysts, they are self-limiting. So in today's MRI, you can see a 5 cyst, but then in the next MRI it can regress to 3 So if it is not very severe, or it is still into mild category, it is sometimes self-limiting. If you reduce your stress level, if you go for pelvic therapies, if you go for overall fitness management, lifestyle modifications, managing your excessive ovarian hormone intakes, like junk foods hai, या other exposures to metallic substances है, या तो excessive use of beauty products है. So all these things, they contain the xenoestrogens, which are not the good estrogens. So shifting your diet to more phytoestrogens or more healthy diets and organic diets, you can reduce the excessive ovarian hormone intake into your body. That is one way to manage. But ultimate treatment would be a surgical thing. And yes, you can get pregnant. Endometriosis will give you difficulty in pregnancy, but if you have taken care of your fallopian tubes and all other things, then you can definitely get pregnant. But if the condition is very severe, which leads to a removal, that is a different story. But we have seen many females with endometriosis conceiving and having healthy babies as well.
I think it has cleared many of viewers' doubt. One more question was, is there a chance for a lady with one fallopian tube to become a pregnant with underlying condition like diabetes and endometriosis?
Yes, she can get pregnant.
And can Dr. Haig's assessment for hypertonus and hypotonus can be applied for unmarried women?
See,
Was one of the questions.
it can be applied for unmarried females also, but remember one thing, with proper consent. we do not recommend it to you. It should not be used into the pediatric population. Below 18 years should never be used without without a permission from the pediatrician or the mother. And even in other unmarried females, like you are seeing a girl who is 22 years old, but she is using a tampon, or she is using a menstrual cup, or maybe she is sexually active, then yes, definitely you can do the pelvic floor assessment into them. But the only thing is, don't do it without consent. That is the most important thing. Take the consent, then do it.
I think we are done with the question. There are many more, but we'll have covered major of it. So thanks a lot, and I'll hand over the mic to Dr. Darshana for vote of thanks.
If any, you can message me on my mobile number.
Yeah, Dr. Dhara has given her number. So any more further questions, you can WhatsApp to her, and she'll definitely reply to it. Very well said and very crisp explained, Dr. Dhara, and definitely looking for one good workshop in Mumbai as well from your side.
Sure. Thank you very much.
Over to you, Dr. Darshana.
Thank you, Dr. Bharti Dave, ma'am. Am I audible? Sorry.
Yeah, Darshana, you're audible.
Yeah.
Audible.
Vote of thanks for today's wonderful evening. First, I would like to thank Dr. Dhara Shah, ma'am. Ma'am, thank you so much for accepting our invitation at such a short notice and an informative session. We all have learned so much from today's session. Thank you so much, ma'am. Next, I would like to thank our very supportive, our central team, who's always helped us in all the webinars. Next, I would like to thank our IAP digital team for providing the Zoom as well as YouTube platform. Next, I would like to thank webinar. Thank you, Dr. Neha. Next, I would like to thank and congratulate our state team that we were able to have such a good webinar. And last but not the least, I would like to thank all the participants. We had a good number of participants on YouTube as well as Zoom. So obviously without you all, any webinar will never be successful. So thank you all the participants. Thank you one and all. And now we are at the end of this webinar. So I would also like to tell you all about IAP registrations. We are having students registration as well as registrations for IAP registrations for bachelor's, masters in physiotherapy. So if you all have any queries regarding registration for the Indian Association of Physiotherapists, you all can feel free to contact any one of our team members. So thank you one and all. We can end this session. Thank you so much.
Thank you, ma'am.